Now, all of this comes at a time when the relationship between doctors and their patients is changing. The empowered healthcare consumer of today is being urged to, indeed in some circles expected to, participate as a partner in the decision-making on many healthcare decisions. Such shared decision-making encounters tackle some of the complex decisions that patients now face. For example, is surgery always the best choice for low back pain? Does prostate cancer screening always make sense for all men? Should a woman in her 40s have mammography? Should we all be on cholesterol-lowering statin drugs? Should a woman with early-stage breast cancer choose lumpectomy with radiation or complete mastectomy? Should a man with early-stage prostate cancer choose surgery or radiation or hormone therapy or watchful waiting? But a study published last month in the Archives of Internal Medicine showed the poor quality of discussions between men and their doctors on the prostate cancer screening issue. The authors found disconcerting that 30% of men in their study underwent PSA testing without first having a discussion with their doctor. And only 21% of discussions presented both the pros and cons, the harms and benefits of screening, and elicited the subject's preference for testing. An editorial in the same journal discussed some of the obstacles for broader implementation of shared decision-making. The editorial stated, what is ultimately required is a deeper change in culture among providers and consumers of healthcare to delay dissemination, resist the assumption that newer is better, wait for evidence, tolerate observation and over-intervention, and accept uncertainty. I thought that was a very powerful editorial statement. As a journalist, I always look in the mirror first. Journalism often makes this picture worse. Contrary to what that editorial called for, journalism usually promotes the idea that newer is always better. Journalism often doesn't wait for evidence. It reacts to whatever is first. The first surgery of its kind, the first use of a new machine, the first use of a new drug, etc. Journalism often has a bias for intervention over observation and is painfully intolerant of uncertainty. After all, who can get excited about a news story about uncertainty and about going slow rather than jumping in quickly with interventions? Well, I, for one, can. Change the slide, please. And on this topic of the lack of shared decision-making involved in prostate cancer screening decisions, I have tracked shocking numbers of news stories that promote screening tests outside the boundaries of evidence, failing to acknowledge the uncertainties and harms that can occur when you screen large numbers of people without having good evidence to support that. So if men are getting messages at home that promote only the benefits of screening and then go in to see a doctor who is, based on that study, 80% more likely to discuss only the benefits of screening, how will truly informed decision-making ever take place? Next slide, please. This is the clash between intuition and science, the collision between what we believe to be the truth, what we want to be the truth, and what we know to be the truth, backed up by evidence. We have all been brought up to believe that early detection always leads to a better chance of cure. How do you overcome that? By educating people about the need for evidence. As the National Institutes of Health outside of Washington, D.C., at the National Institutes of Health, Dr. Barry Kramer says that this conflict, this collision between intuition and science, has the potential to damage the relationship between doctors and patients. He said, when we convince the public that a procedure is beneficial before we have the facts, it's hard to come back and say, well, we've now found out we were incorrect. It calls into question the credibility of organizations releasing guidelines, and it leads patients to question other recommendations that we make. We can't know that prostate cancer screening of every man over age 40 saves lives until we have the evidence to show that. We can't know that million-dollar proton beam machines to treat cancer are better until we've done the studies to show that. Yet, there are intuition-driven proclamations from professional medical groups about screening tests that subsequently are reported unquestioningly by unskeptical journalists. In the U.S., perhaps more so than in other countries, we've allowed the high-speed train of expensive new technologies to leave the station before all the evidence is in hand. And once that train is headed down the tracks, that train just picks up more speed and more momentum, and there is no stopping it. That's how we, at least in the US, went crazy over high-dose chemotherapy and autologous bone marrow transplants for metastatic breast cancer until we realized that the treatment was hurting far more women than it was helping. That's how the painkiller drug Vioxx got on the market and was advertised and reported by journalists as a super aspirin before questions about how super it was and how harmful it was were answered. That's how intensity modulated radiation therapy and proton beam machines are spreading across the US, multi-million dollars of investments without all the evidence on effectiveness. But you see, true believers just know that all of these ideas are better because they want to believe that. And they may not want to wait for the evidence. The education of the healthcare consumer is so important, and it is so much in jeopardy. Consumers are flooded by information, and they don't always have the ability to judge the veracity, the truthfulness of the information, or the integrity of the source. The journalism that they once depended on for independent vetting or filtering of claims has its own troubles and may not be the filter that it once was.